DKA. I try to squeeze the material in under 30 minutes, and I'll try to squeeze it. I try to finish it in, but it's a very long subject, and the interconnection is wide. Anyway, we're gonna start with simple close-up look for the pathophysiology of DKA. In simple words, DKA or diabetic ketoacidosis for sure is happening when there is a patient with diabetes mellitus type 1 who have hyperglycemia, ketoacidosis, and dehydration. And the causes of that is either no insulin at all, or there is increase in demand for insulin. For example, in our case that we faced it's not a real DKA case, but his cause is he stopped the treatment, as mentioned here, and if there is a misdose in the regimen of the patient, maybe precipitate DKA. If he is a newly diagnosed case and the first presentation of diabetes type 1, maybe diabetic ketoacidosis, and especially in kids. Also, pancreatitis can cause deficiency in insulin and can present it as a case of DKA. For the increase of demand of insulin, any ideas how the increase in demand in insulin can cause DKA? I'll start by major trauma can cause, and anyone can participate. What's the
infection?
Yes.
Infection. Okay, that's correct. What else do you guys? Any kind of stress that can increase the demand of surgery. Pregnancy. Hyperthyroidism also. Please, if you thought of anything, just talk. It's an open discussion. GI bleeding also. And
obesity.
MI. Obesity.
Yes.
There's if we talking about a severe demand or insult to the systems and severe stress, and some documented cases of abuse of cocaine also precipitated the attack of DKA. The most important thing here is always exclude the possible causes that cause DKA through a good history, and I'm talking about MI, so that will be appearing in ECG, and history of infection also is very important, especially in old age. A little glimpse of pathophysiology. The pathophysiology of DKA is depending on how the different tissue handle glucose under different metabolic state. So just to think about how many metabolic state that we have actually in our body. What do you guys think? It's 2 metabolic state to be fair. It's either it's
anabolic and catabolic.
Anabolic and catabolic, exactly. It's anabolic or catabolic state, or fed state for sure, and starvation state. And this is 2 different hormones. This is the liver, and sorry for my drawing if it's not apparent. This is the liver, and the liver controls the 2 metabolic pathways, the anabolic and catabolic pathway. The anabolic pathway, as I color-coded here, is dominated by insulin, and the catabolic state is dominated by glucagon. What happened in anabolic state, the glucose actually turn into always that whenever we have a lot of glucose, the liver will turn it to glycogen. Exactly, glycogen in anabolic state, and the free fatty acids from food, from free fatty acid in the system, will turn into triglyceride, and triglyceride will shift to fat tissue in the peripheral or in the liver. In the liver, so we'll call it fatty liver. Sometimes it comes to the point that it is disease state. It's called fatty liver. And in the subcutaneous tissue, which regarded as an overweight or obesity. This is in fed state. Whenever we have starvation, it will be associated with low blood glucose. This is very important. And with the starvation, there will be two hormones responsible for that, responsible for the management of the metabolic system of the body. It is the glucagon and catecholamines. The glucagon, in the glucagon state, the liver will actually turn the glycogen inside it into glucose to support the system, and turn the amino acid that comes from the muscles. If you see down here, in the catabolic state, the muscle will pump out amino acids into the system so that the amino acid will turn into glucose also in a process called gluconeogenesis. Free fatty acid also comes from the fat tissue that's been stored and also turn into keto acids. Mainly keto acid are in the diabetic ketoacidosis is beta hydroxybutyrate and acetoacetate. And surprisingly, in diabetic ketoacidosis, the body will synthesize the beta hydroxy.
I think okay.
Okay.
Yeah,
So,
thanks a lot.
Where we at?
مدام beta hydroxybutyric acid, the beta hydroxybutyric acid step.
Oh, okay, yeah. So in ketoacidosis, the body will synthesize a beta hydroxybutyrate and acetoacetate, as I mentioned here, but it synthesizes beta hydroxybutyrate three times more than the acetoacetate. This is very important in diagnosis, and we'll see this point will play a big role in case of differentiating the ketones in the urine. In DKA, the liver thinks he is in a starvation mode despite the high blood glucose because there is no insulin. So there is no insulin. We are in a catabolic state. So the muscle will release amino acids. It will go to the liver through gluconeogenesis, will produce glucose. Also, the glycogen in the liver will produce glucose despite the high blood glucose level that can reach to 500 milligram, which exacerbate the problem. The glucose will cause hyperglycemia. Hyperglycemia the glucose go to the kidneys. The kidneys will excrete the glucose in the urine. Withdrawing with it, the water that cause dehydration. Also comes out with the water is minerals like potassium, sodium, calcium, phosphate, and magnesium. So this is the start of metabolic derangement of ketoacidosis. Also, the fat tissues excrete fatty acids, go to the liver make ketones, the two ketones that we talked about, ketones secreted in the blood, the beta hydroxybutyrate and the acetoacetate will elevate the pH of the blood to more acidic state and causing acidosis, which is adding of the acid to the blood will cause a wide anion gap metabolic acidosis. We'll talk about it a little bit later. Just a quick look at what's happened. What's the diabetic ketoacidosis effect on the potassium? As you see here, the potassium is lost in the urine, right? Sometimes or not sometimes, about the literature says like 40%, 4% of the cases of DKA, you will see hypokalemia, despite there is a loss of the potassium in the urine. So it's contradicting because we're losing potassium in the urine, but when you measure the potassium in the blood, you will see it actually normal or sometimes elevated. And to explain that is because there is a concept about osmolality. And to explain that is when we lose water from, this is a cell, this is any cell of the body. If we lose more water from the plasma, actually the concentration falsely increase of the potassium. This gives you a false increase of potassium concentration in the plasma, but the total potassium is actually decreasing. Another cause, because of we have a high hydrogen ion in the plasma because of the acidosis, this will be replaced. This is the hydrogen will go inside the cell and the potassium goes out of the cell as a protective mechanism to the body treat itself from acidosis. So it takes the acid in and gives the potassium inside of the cell out. Normally, we have more potassium inside of the cell, about 98% of the potassium is inside of the cell, and only 2% is outside and in the circulation. And obviously, the absence of insulin, the role of insulin and the effect of insulin on potassium ion is to get the potassium ion inside the cell and get the sodium out. And in case of there is no insulin, you see a reverse of this process and increase potassium outside. So this is 3 reasons why you will see a high potassium in the high or normal potassium in case of DKA, despite we are losing it inside from the body through the urine. Effect on the brain cells, dehydration also will cause hyperosmolarity of the plasma, and hyperosmolarity of the plasma will pull the water from the brain cells and cause the brain cells to shrink. Shrinkage of the brain cells will give you a presentation as a nausea, vomiting, or change in the conscious level, or disoriented or drowsiness. This is playing a major role in the correction phase of the dehydration or the DKA. If you correct very rapidly, you may precipitate. So if this is a normal, let's say this is a normal saline, and you correct it very rapidly, the normal saline and the correction will drive the water inside the nerve cells so fast, and it's going to be swelling and will be appearing as brain edema. So we will see in the management how we extend the management through 12-hour first phase, then second phase of 12 hours. So we treat over like 24 to 36 hour fluid treatment. And this is the effect of the DKA, and the correction, and the point of correction should be very slow fluid correction to avoid. This is especially important in children. So DKA in children, just be careful in the correction phase. The pH, dropping of the pH below 7.35. Are you guys hearing me?
Yes, I can.
Yes,
Yep.
proceed.
Yes.
Dropping of the pH less than 7.35 is called acidosis. Acidosis means increase in the hydrogen ion in the plasma. And the cause of that, as we said, is the 2 keto acids that we know. And this will be compensated by, so in case of you have high hydrogen ions in the blood. The respiratory compensation will be hyperventilation, and this is explained why because we have what we call it above the carbonic acid. This is the buffer for the hydrogen ions, so it will be flowing in the blood freely and will be dissociated to H2O and CO2. This CO2 will be blown off outside the lung, outside the system. And the other part of the equation is the bicarbonate plus the hydrogen ion that comes from the release of the butyric acid and acetic acid. So it takes this hydrogen ion from the blood and out to the air, the outside. It's neutralizing this hydrogen. And in this process, actually, we will use a lot of bicarbonate. And that's why one of the signs or diagnostic signs of the diabetic ketoacidosis is the dropping of bicarbonate. It's because we overuse it to blow off oxygen, CO2 from the lungs. I'm not going to discuss the metabolic acidosis and differentiation from the metabolic acidosis on the basis of the anion gap. It's going to be time consuming, and so I will skip that. Maybe in later another presentation we'll take that. Sign and symptoms. So polydipsia, polyuria, and two are caused by increased glucose. This is obviously a well-known complication. Nausea and vomiting, and there is a lot of causes of that. One of it is acidosis that's stimulating the vomiting center and cause more vomiting, and the vomiting cause more dehydration, and that can cause exacerbate the problem. Also, nausea and vomiting can be caused by inflammatory mediators, the catecholamines that increased by stress. Abdominal pain, change in potassium ion, either increase or decrease, will cause ileus, and that one cause of the pain. Also, hyperglycemia can affect the liver because the liver is receiving a lot of fatty acid of all these metabolic products, amino acid, and start to convert it into glucose. So the liver is working overtime, and the concentration of solutes inside the liver cell is so high that would cause some kind of cellular swelling and causes pain by stretching of the liver capsule. Shortness of breath, of course, as we said, the compensation of metabolic acidosis is, as we said here, is blowing of the CO2 outside. And in order to help that, the body will respond as increase in the depth and rate of breathing, which is characteristic breathing. You guys actually, you know what's called the cosmal breathing. This characteristic signs of the DKA patient because he wanted to compensate for that acidosis. Also, the dehydration can cause decrease of the lung compliance. The lung is so thick because of the dehydration that the patient cannot actually move it. So he feels shortness of breath. This is two causes of shortness of breath. Signs, of course, heart rate will be up, blood pressure will be down, dehydrated, respiratory rate will be up, the breath, I draw a fruit here because it's what they call it, fruity breath, because of the acetones that comes out because of these acids. Dehydration signs, dehydration of the mucosal membrane, concentration of urine, all the signs of dehydration, mental status alteration, and fever. Sometimes the presentation is without fever. and that does not exclude the infection. The diagnosis: blood glucose is more than 250 milligram. Sometimes with history of alcoholism and liver disease, the blood glucose will be normal. Do you guys know any ideas why?
Is it
So
because the liver's not making enough glucagon?
exactly, it's just some sort of that is because the liver is so damaged that it cannot do gluconeogenesis. And you know, the glucagon storage of the liver is small, not too big, so it's gonna last for maybe for 2 hours maybe. But the more extensive cover for the deficiency of for deficiency of glucose, as the liver thinks it's starvation, is gluconeogenesis. Gluconeogenesis is defective in case of alcoholism and liver disease, so that sometimes in DKA with liver disease and alcoholism, blood glucose will be maybe slightly elevated, not too much, just to keep in mind. Urine test, we will see ketones, and here's the point I've told you about why we should keep in mind that we are synthesizing 3 more beta hydroxybutyrate, because in urine test we only detect the acetoacetate, especially with the tests that contain nitroprusside or agent. So in that case, we're actually detecting only small amount of the ketone in the urine, and the better assessment is the blood, especially for beta hydroxybutyrate. This is more accurate, and will play a role actually in the correction phase. So when we start correction of the DKA and we will give insulin, a lot of the beta hydroxybutyrate will convert it back to acetoacetate, and this will give a false increase in ketones while we are treating. So we are treating the patient first phase, and we detect the urine and see a lot of the ketones coming up, and the ketone will be 2 plus 3 plus something, and we will get confused what's happening. We are treating the patient, but the ketone in the urine is increasing. It's not actually increasing. It's because when we start insulin therapy, the beta hydroxybutyrate will convert it to acetoacetate. Sorry, and this will give you a false indicator of the increasing ketones. ECG, as we said, we will have a state of normokalemia or maybe hyperkalemia. So we will focus on hyperkalemia effect on ECG and DKA. I don't know how this is correct or not, but I just found it in the textbook. If they start, so it is a timeline of how the effect of the potassium on the ECG. So at the start, we'll have a tented T wave in a level of 5.5 to 6.5 milliequivalent. This is the serum concentration of potassium. Loss of the P wave or increase in PR interval in around this range, 6.5 something. Why the QRS is in 7.5 to 8.5. I would say, for a matter of simplicity, just remember, if you see tinted T wave in case of a DKA, just remember that you are well above 5.5. And anything further, that's you actually cross the 6.5 level. And of course, confirmation of this through the lab. If the potassium ion is decreased in case of hypokalemia, we will see a flat T wave. Is also, we always see the effect of potassium at first on the T wave, then it's going on to the other waves. The effect of hypokalemia we see as a flat T wave or ST segment depression, and that's been we reach the level of less than 3 milliequivalents of potassium concentration. And the other effect of ECG is the appearance of the U wave, increased QT interval, and at last we will see toxad rhythm. and actually this is going to be very emergent cases. They take surprisingly they take venous blood gas rather than ABGs. They said it's more easy, but I think if it's if the ABG is available, it's both of them have role. But as a matter of diagnosis, anion gap in the venous blood gas is the anion gap is 9 sorry, more than 10. What they mean by the anion gap is just simple or quick explanation. Anion gap equal to concentration of sodium minus chloride plus the bicarbonate. This is negative and this is negative, and that's why I call it anion. Anion means the negative ion. Cation means the positive ions. So it's an ion gap. So whenever the normal range is actually 8 to 10, I guess. Yes, 8 to 10. If it is more than 10, that is an increase in the gap of anions. What does that mean is we actually adding more acid to the system. That's, as we said, beta hydroxybutyrate or acetoacetate. We're adding more acid. We're consuming more bicarbonate, and the chloride is fixed. We didn't change the chloride. But with the normal ion gap metabolic acidosis, well, what will happen is actually decrease the bicarbonate and increase the chloride. It is acidosis, but with increased chloride. So it is give you, if it is the decrease and this increase in the same rate, and there will be no there will be a normal anion gap. The bicarbonate will be less than 15. As we said, we will lose in bicarbonate, and the pH will be less than 7.3. Liver function test actually will be seen elevated because there's infiltration of fat, and inflammatory mediators will be high, so it will be corrected during the treatment. White BC, if you see more than 10,000, this indicate infection. Differentials, one of it is alcoholic ketoacidosis, starvation, renal failure, lactic acidosis, and toxins. And by the toxins, I mean salicylate, ethylene glycol, or methanol. The treatments, as I said, we go slow on that. So the fluid treatment is normal saline. So the trick here is we divide the time of the treatment by the 24-hour. We divide it by 2. 50% of the fluid treatment in the first 12 hours. And we give it as a 2 liter in the first 2 hours, as color coded here, 2 liter in the second 4 hours, and 2 liters in the remaining 6 hours. So this is 12 hours. And the other fluid is in the rest of the time left. The average deficit that we give is we give 100 ml per kg normal saline for that fluid. Just a quick note here, blood glucose, if the blood glucose reached 250 milligram during the treatment, we shift to 5% dextrose, and we put another line with 0.5 normal saline, 0.45 normal saline to prevent an increase in chloride concentration. So we use half. So normal saline is 0.9. We use half the concentration of normal saline to prevent an increase in chloride, because we are giving norm NaCl. So we are afraid from hyperchloremia. If the patient in moderate dehydration state, we can go ahead with 500 ml per 4 hours. How to correct for potassium? As we said, the potassium is 2% inside the vessels and 98% is inside the cells. Generally, we have low total potassium. So we will correct it if we have the initial potassium is so as we said, if low potassium, if low initial potassium, that means severe total loss. So usually we have normal potassium or high, but if we find the potassium is low, that means the total loss is so much in case of severe cases. And we have to replace it within 24 to 36 hours. If the initial potassium is more than 3.3, this is a number to remember, to 5.3 with a good urine output, the rule is 10 milliequivalent per of KCl per hour. And we measure for 4 hours and measure 2 hourly with infusion of insulin, of course. And if the initial is less than 3.3, do not start insulin, because this is very dangerous, because the insulin will drive the potassium inside the cell and will exacerbate hypokalemia. We will wait 30 minutes before giving insulin. We will give potassium first, correct the potassium in a rate of 15 to 10 milliequivalent per hour, and start insulin if the potassium is more than 3.3. Insulin is very simple, is 0.1 per kg per hour. And again, if the potassium is more than 3.3, this is very important number to keep in mind. And monitor the response. The response will be decreasing of blood glucose 50 milligram per hour. So 50 in the first hour, 50 in the second hour, according to this rate. A quick, very important note here: discard the first 20 ml of insulin, because the insulin will bind to the plastic of the IV set. So the first 20 ml of the mixed infusion normal saline with insulin, just discard the first 20 ml because it will be that, because it will be there will be no insulin inside this 20 ml, because all the insulin inside this 20 ml will be bound to the plastic of the IV set. Subcut is the same dose, but they don't advise, because we cannot control the flow of the insulin and the the concentration as in the infusion. So if the blood glucose drop below 250, we'll switch to decrease the insulin to halve the dose, and switch to we add glucose to the treatment regimen and decrease the concentration of normal saline to the half, so we avoid hyperchloremia. And the reason behind continuing the glucose and the insulin, even the blood glucose is dropped to 250, because the ketoacidosis need more time to be corrected. The hyperglycemia will be corrected easily and fast, but the ketoacidosis will need more time. If we stop here, the ketoacidosis will bounce back and the patient will be in acidosis again. So the treatment should be continued until I think 24 to 36 hours. Bicarb is not recommended in the treatment per the textbooks. This is the detailed timeline. I tried to summarize it, but this is the detailed treatment from the emergency medicine textbooks. And thank you for watching, and sorry to extend the lecture. Thank you very much.
Thank you, Dr. Amar. That was really interesting.